Hello everyone, this is Chadi Alraies from SCAI 2022. With me is Dr. Nishtha Sodhi. She is director of the valve program at University of Virginia. Nishtha, always nice to see you.
Absolutely. How are you, Chadi?
Fine, thank you. You did phenomenal sessions earlier today, but definitely the tricuspid valve is your thing, and you want to grow in it, and there's a lot of technology. So tell us a little bit about it.
Sure. Thanks for having me, Chadi. You know, the tricuspid space, we just a few even years ago were, saying that it's the forgotten valve. And here we are, and it is certainly no longer forgotten. And really, at this stage of where we're at in the field, I think there's so much that we don't know. But what we do sort of know at this point is, I think, spending a lot of time in diagnosing the severity of tricuspid regurgitation and fine-tuning the patient selection in terms of understanding who will benefit from our tricuspid therapies. Right now, I think that, even on surface transthoracic echoes, the severity of TR is often missed, and even our understanding of grading the severity is still evolving. We often, look to Dr. Hahn's classification, and that is something that is evolving for us to learn about, and for us to, when we're doing the echoes and scanning our patients, really understand. I think the other piece to grading and looking at echoes is also understanding our patients. And, the classic TR symptoms, while present in many patients and what we can often use to understand the sequelae of TR, a lot of patients also with severe TR have sort of non-specific symptoms that may not trigger a cardiac etiology on surface level. And as we understand this disease process, I think that sometimes understanding that they may present a little atypically with some of these unusual symptoms is also key to understanding how they may do. I think also one unique thing about the tricuspid space that we're probably going to evolve as a field is that our heart team is probably going to include more people in different subspecialties. Heart failure specialists for sure, of course, as we've learned about from the mitral space, but I think there's also, at this early juncture, definitely space for our palliative colleagues to understand the outcomes and trajectories of some of these patients at this early stage. I think also having buy-in and conversation with our pulmonary hypertension colleagues to understand RV hemodynamics and the sequelae in terms of remodeling with pulmonary hypertension is also a key feature and a key part of our discussions. And so I think, on even the pre-screening front, there's so much that I think we're learning, and it's such a different landscape than, for example, the aortic valve and even the mitral valve. And so having, I think, a very broad heart team, particularly for tricuspid, is very important. I think, once we've identified patients as a true heart team about who may go on to get therapy, the exciting thing is there are definitely a variety of different types of devices that are being developed and that we're studying. So anything from leaflet repair with edge-to-edge technology, looking at the TriClip system using sort of the MitraClip-like technology, to the edge-to-edge repair system with the Pascal device in clasp TR. And then certainly on the valve replacement strategy side, we've had good results early on that have been presented by Dr. Kadali and colleagues with the Evoke platform from Edwards. And the third sort of, device strategy would also be cardioband TR, looking at annuloplasty. And so I think it's, as we're starting to understand how to grade severity, how to understand how do we select patients. We also have this exciting frontier where there are new devices being developed to help target. And I think, 5 years down the line, we may start combining some of these therapies and sort of getting better at matching which patient does better with which device.
Well, the most interesting thing you mentioned is the heart team approach, but now you're going to have pulmonologist, palliative care, which is never crossed my mind.
Right,
Yeah.
exactly. And I think right now, early on, I think those having those colleagues is important to really understand patient selection and also family discussion and overall care for the outcomes of our patients.
Well, Dr. Sodi, thanks so much for your time.